Welcome to the Global Hemophilia Report, a podcast where science and storytelling drive change. Produced by Believe Limited and Bloodstream Media and made possible thanks to our featured advertiser, Sanofi. In partnership with my colleague, Senior Scientific Advisor, Dr. Donna DiMichele, I am your host and resident person with hemophilia, Patrick James Lynch. Today's topic is a personal one for me. It's a personal one for a lot of people. Mental health, or more specifically, the intersection between mental health challenges, bleeding disorders care, and crisis prevention. Another critical conversation here in the Global Hemophilia Report with another outstanding group of contributors. We'll meet them and dive in right after this.
Sanofi seeks to break barriers for people with hemophilia through groundbreaking science so they can live beyond the limitations of their condition. Learn more about Sanofi's commitment at redefininghemophilia.com.
In 2021, a 20-year-old man with hemophilia made a decision that so many never do. He admitted he needed help. He asked his care team to find an inpatient treatment facility for substance use. That kind of honesty, that kind of vulnerability is rare in a community where hardship is often masked by the words, "I'm fine." But every facility they called said no, because he needed IV infusions. They labeled him too complicated. He was turned away, and a few weeks later, he overdosed and died. This episode starts there, not to shock, but because it shows what happens when a system built on misunderstanding meets someone finally ready to speak up.
It's always so unfortunate that we have to have a tragedy first in order for us to grab our attention.
I think it reveals that there is bias and misunderstanding in the system. People with bleeding disorders should have the same access to inpatient residential treatment the same way as anyone else.
It's our job to provide the supports and the tools needed for success.
We'll examine how struggle becomes invisible when it's normalized, how resilience can mask suffering, and why it's so dangerous to assume that I'm fine means everything is okay. We'll also deconstruct the disability paradox, this idea that people with chronic illnesses often report satisfaction even when they are struggling. And we'll hear from advocates pushing for one simple truth: needing help should never disqualify you from receiving it. So let's have this conversation with our panelists, starting with a round of introductions.
My name is Kate Bazinsky, and I'm the chair of the Bleeding Disorder Substance Use and Mental Health Access Coalition. Say that 10 times fast. We just call it BD-SUMAC, adding to the alphabet soup of healthcare acronyms. I come to this work as a mom. So I have 2 kiddos, and my 9-year-old son has severe hemophilia. So I'm a community member, and my background is in politics and health policy.
And Kate, at number 2, first as a mother of an adult with severe hemophilia A. I also happen to be a licensed professional counselor, and I'm the founder of a company hoping to build awareness of mental health within the bleeding disorder community called Mental Health Matters Too.
I'm Randy Curtis. I'm currently the president of the board for the Northern California Hemophilia Foundation, and I've spent the last 30, 40 years doing research on the cost of care and the burden of illness in hemophilia and other bleeding disorders.
My name is Jackie Bottacari. I am a clinical social worker at the Yale Hemophilia Treatment Center, or Yale Center for Bleeding and Clotting Disorders. And I am part of the coalition BD-SUMAC, or Bleeding Disorders Substance Use and Mental Health Access Coalition.
Hi, everyone. I'm Donna DiMichele. I'm a pediatric hematologist, but most importantly, a senior advisor to the Global Hemophilia Report. And I'm just delighted to be here with you all.
Kate, I want to start with a question for you, and it was something posed in the opening of this episode. When patients are denied inpatient treatment due to IV infusions needed to manage their hemophilia, which can be labeled medical complexity, what does that reveal about bias and misunderstanding within the system?
I think a lot of the beliefs around medical complexity are outdated and based on fear and stigma rather than a true understanding of what bleeding disorders mean. Many of the facilities who deny folks with bleeding disorders based on medical complexity don't really understand what it means to have a bleeding disorder. They have maybe heard of a bleeding disorder, and it just sounds scary. They're concerned that maybe it involves a lot of blood and bleeding, and they don't take the time to really understand what it would involve to have them stay in their facility.
So if the systems are stacked against people with bleeding disorders, then they might not access the care that they need before it turns into a crisis situation, right? You know, one thing that I always like to say is that heart disease or heart conditions, right? That's not really rare. A lot of people know what a heart condition is, right? So if you go to your doctor and your doctor says, you know, you have a heart condition, you know, you need to go on X, Y, and Z medication, or you need to follow through with some type of treatment plan, you're most likely going to follow through with that treatment plan, right? There's going to be no questions asked.
The National Bleeding Disorder Foundation's Medical and Scientific Advisory Council actually weighed in on this issue last year. They released a statement, document 289, which says that if a person with a bleeding disorder is medically stable and well managed on their medication, it should not be a reason from exclusion from an inpatient or residential treatment facility. And they go even further to talk about this issue of medical complexity. And they say, although providers may not be familiar with bleeding disorders, and it can be very complex to identify the proper treatment protocol for an individual, once someone is well established on their treatment protocol and they're medically stable, then the daily management of bleeding disorders is not complex and should not be a reason for exclusion from care.
But we know that people, you know, with chronic conditions such as bleeding disorders have a higher rate of mental health diagnoses or disorders, especially anxiety or depression.
What I really want to see within the HTC systems, and I want to be really sensitive about this because I don't mean it criticism in any way. I think the HTCs were formed in the 70s for very good, noble reasons. And they are, in fact, companies of care in terms of staff. You know, we have a collection of people that we need to be seen by. But we know so much more about the mind-body connection now. We know so much about the interrelationship between mental health and physical health, and how physical health affects us mentally. I would just like to see some kind of knowledge upload so we can recognize the signs and symptoms.
It's important to acknowledge and see these warning signs that maybe you do need some help or some issues need to be addressed when we are talking about mental health. So for instance, we use terms like resiliency. People with chronic conditions like hemophilia sometimes say, well, I don't need mental health support. I'm completely fine, right? I'm resilient.
The disability paradox. So it suggests that people like us with chronic conditions are often reporting higher satisfaction than our peers in the general population. Two-part question. Why do you think that is? And what dangers come from taking that satisfaction at face value?
Well, I think that even within the hemophilia community, when we did a study on older people with hemophilia back in 22, and the guys that were in their 40s looked at the guys that were in their 50s and thought they were in worse shape than the guys were reporting that were in their 50s. Because the guys that are in their 50s and 60s, when they look around and look at their peer group, even though they may be fairly disabled, they're better off than Bob, and Jack is dead. So comparatively, they're fine, right? Whereas the younger guys look at them and say, my goodness, this guy's kind of jacked up and he can't get around very well. So on a scale of 1 to 100, the guys that are older may say, I'm at 70. And to some extent, that's kind of protective. That's back into the I'm fine role. It's like, as long as I put a 70 on there, my doctor's not going to ask me any difficult questions. As long as I put 70 on there, people are going to leave me alone. Now, we have some other tools that measure depression and anxiety. They're a little more subtle than that. And when you look at those, they'll show a different picture. But if you just ask somebody how they're doing on a scale of 1 to 100, 70 is the number I'm going to give you.
You know, I notice that we'll be talking about entrenched resiliency, almost as if it's a maladaptive or a bad concept, a bad way of moving on the world. Resiliency itself I really want to speak to the positive part of it. It is when you accept that this is part of me. It's when you can then look at what you can control. Those are the more adaptive parts of resiliency.
So I went to school in a wheelchair. I had braces on my ankles and my elbows. And, I was not allowed to go outside at research. I had to go into the school office. So I was socially isolated there. But I was a fairly gregarious guy, and I made friends, and and it was very popular to push me around in my wheelchair. So my technique for managing my mental health was to be very upfront with everybody and let them know I had hemophilia and embrace that.
But you're talking about when we put up the mask that we're fine. And really what I want to speak to is that the cost of this is the cost of quality of life. That's really how I see it. Because when I'm in a physician's office and I say I'm fine, but I'm not talking about how anxious I am that I will lose my job or lose my health insurance, really nothing has changed for me. So I would have to say, positive change, interventions that really speak to what's holding me back. That's the biggest thing that gets lost when we stay in the mask that we're following.
You are resilient, and maybe you've come a really long way or really far away with your bleeding disorder care, doesn't mean that you can't care for your mental health as well.
But there are people that don't have my personality that are much more socially isolated and picked on, actually, as being different. So I think, a lot of it has to do with the personality that you're born with. I don't think this is something you can teach somebody. But I was always very upfront. I was always Mr. Hemophilia, and my cousin was the opposite, and he told everybody he had arthritis, and no one knew that he had hemophilia. So that's just different ways that people deal with it. And my cousin wound up getting in a jam, and nobody knew he had hemophilia, and he passed away.
So we're talking about crisis. We're talking about normalizing hardship and how that normalized hardship can lead to crisis. I want to zoom out a little bit more and ask a question open for the group in general.
#MyHemophiliaTruth. Real stories powered by Sanofi. It's time to consider the whole experience when it comes to managing hemophilia and change the conversation. Explore the full story at www.myhemophiliatruth.com.
Randy made the point earlier. I know if I fill out a 7 out of 10 on this mental health eval inside the clinic that nobody's going to ask me anything. Nobody's going to bother me. And you know what? I do the same kind of thing. Even if I am struggling, when I'm inside the clinic and there's a question about how's your mental health or in the last 30 days, how many times, I'm not always honest. I'm probably dishonest more often than I'm honest, if I'm being honest right now. And I'm somebody who is, like Randy, willing to talk about this stuff. So if someone like me and someone like Randy aren't willing to be more transparent about what's really going on in that moment, how do we help people get more honest in the moments where that honesty could actually lead to a meaningful intervention?
I think, first of all, when someone doesn't speak up and say, I'm not okay, they forego the opportunity to actually become okay. And I think the other piece is that if people are able to admit that not everything is fine before it reaches crisis, they actually have opportunity to get treatment. And people do put it off as long as they can. And there are a lot fewer options for them if they allow it to reach a crisis. So I think it's an important conversation for our community to have.
83% of referrals for inpatient substance use treatment for people with bleeding disorders are denied. How does that level of rejection impact a person who may be seeking help, knowing that chances are 4 out of 5 times I'm not even going to get that help in the first place?
I think it's important to take a step back and really look at Why is somebody accessing inpatient treatment for a substance use disorder? And one word that comes to mind is motivation. So someone who's motivated for change. If I have a patient who comes to me and says, I really want to address my substance use and I am ready for change, I'm going to support this individual in any way I can. But when they're denied from a treatment program, this can cause rejection, as you had mentioned. And unfortunately, that motivation might dwindle.
I have one coalition member who asked for help on many occasions before someone finally said yes. And he talked about it as having these windows of opportunity when a person is ready to make change in life. And when someone says no, that window closes. And he said every time a facility said no to him, he went right back to using.
The next time they might need help, they might not come to me, or they might not try and access an inpatient substance use treatment because they were denied so many times in the past.
I think it speaks to how broken the system is, that it would turn folks who are really looking for help and ready in that moment away from recovery.
I want to make a point. So keep in mind that up until recently, people with hemophilia were not allowed into skilled nursing facilities because they were too medically complex, right? And we went to a lot of work to try and get change at the federal level to get Medicaid and Medicare to approve the ability for people with hemophilia that required an IV infusion to allow them to be in a skilled nursing facility or assisted living facility. Up until then, the care of hemophilia patients that were in these facilities was their son had to drive over and put them in the parking lot and infuse them in the parking lot. So we've already been there, and maybe we need to have a new legislative push to change this at the federal level. I'm just saying.
Absolutely. And there are some commonalities between this issue and the skilled nursing facility issue. A lot of what was driving the denials in skilled nursing was payment and the very large expense that's associated with factor medication. And the skilled nursing facilities didn't want to shoulder the cost of our factor because it would come out of their per diem that they got from Medicare. We are seeing that somewhat, and we think that we will see a little bit more around the cost concerns with regard to inpatient residential mental health and substance use treatment facilities. But what we're seeing more here is concerned around needles, around fears of allowing people to infuse in an inpatient residential mental health or substance use treatment facility, and just fear about people who have bleeding disorders.
But in reality, the main focus of these substance use or mental health treatment programs are on behavioral health issues. So they actually don't have the staff to, really examine or look at other conditions besides, the mental health or the substance use.
The two studies that we have on this issue are located in Houston, Texas, and they did an analysis of all the inpatient psychiatric facilities in the city of Houston. And they found that 100% of the inpatient psychiatric facilities, both the pediatric and adult facilities, exclude people who use IV infusion medication. That's their explicit policy. And we have found similar policies in Michigan, Wisconsin, and Minnesota, and wherever we can find these policies. Not all facilities, but many of them have these specific exclusions for people who use IV medications. And I think that that's for a couple of different reasons. One, I think that people have a preconceived notion of what an IV infusion looks like.
A few years ago, I presented to the Connecticut Hospital Association about these issues we are seeing of denials for people with bleeding disorders to inpatient or residential treatment programs. Everyone in the room was astonished. I mean, they were so taken aback when I showed them a picture of what a butterfly needle actually looked like, right? So when they thought of IV infusions, they thought of like lines and bags and poles. And when I just showed them in my hand how it was like the palm of my hand and just how tiny a butterfly needle was, and that's all my patient uses to infuse themselves.
We have this image of the IV pole with the hanging bag and it taking a very long period of time for that IV to run. I think it also conjures up ideas of someone who's medically frail. And those are simply not the case in our community.
So it changed their perspective of how somebody with hemophilia might look within an inpatient or residential treatment program. And I think that is an important thing to address, is that education is so important. And I think it's our jobs as hemophilia treatment centers or social workers to really educate the community of behavioral health providers of what a bleeding disorder looks like, right?
We've made some progress. When we began this work, there was some language in the American Society for Addiction Medicine. They are the national organization that helps treatment facilities determine where their patients should be placed, so what level of care they need. And there was some language in those guidelines that suggested if you used IV infusion medication, you needed to be in a hospital level setting, so level 4 setting of care, which is pretty much medically managed detox and would preclude people like us, people who require factor medication, from getting access to longer term, the 30-day programs.
And we said, wait a second, somebody with hemophilia does not need to be in the hospital, especially if their hemophilia is stable and well managed, right, by those small little butterfly needles, right? And now we even have injectable medications. So they don't need to be in the hospital.
So we were able to talk with the American Society for Addiction Medicine, and they released a new policy, the 4th edition of the ASAM criteria in 2023. And it now says that as long as a condition can be self-managed, and they use the example of hemophilia in the guidelines, they should have access to any level of care.
And I find that as one of the biggest wins, because this is an organization whose primary focus is on substance use, and yet they incorporated language. They actually say the word hemophilia in their criteria. And this is a criteria that almost all substance use treatment programs throughout the entire country utilize when accepting patients into their programs.
It's encouraging to hear about the victories and the precedent that is being set to see change happen in a more holistic, nationwide way.
So I'm wondering whether the changes in the hemophilia treatment landscape itself can actually help, even as, rightly so, we try to change the rules and the policies to an anti-discriminatory place. So now, I guess my point is we can, for a 30-day stay, we can potentially give a person with severe hemophilia or non-severe hemophilia a dose of emicizumab that would, potentially prophylax. And again, this would take some planning because, of course, you have to transfer someone onto a new therapy, but that would obviate anything but emergency therapy for a 30-day period.
We actually had a case in North Carolina where the treatment team did just that. An individual was not able to get access to a treatment facility while he was on his factor medication. It required an infusion, and the facility simply said no. So the treatment team did some creative brainstorming with the facility and said, okay, well, what if we change the person's medication protocol and move to an injection medication? And the facility said, okay, we'll take someone who injects the medication. And so that was a real success story. It's not what we want to see necessarily. I see that as a form of non-medical switching. because the reason for changing the bleeding disorder care and protocol had nothing to do with the person's bleeding disorder. It was really because of inequitable policies at the facility level. But because the treatment team was able to advocate for the individual and think creatively about the full picture, this person was able to get access to the treatment he needed.
It's an interesting catch-22. On one hand, good for that person, but on the other hand, you don't want to set the precedent that a non-medical switch is what's required for someone to be inside a facility. So I appreciate kind of both aspects of that particular case study.
Emil lives with hemophilia A. He enjoys his career as a teacher, performing in community theater, and spending time with his family. But what you don't see is how living with hemophilia has impacted his mental health. Emil bravely shares his story how hemophilia has impacted his mental well-being and emphasizes how evaluating mental health should be the standard of care that all hemophilia patients receive. Scan the QR code or click the link in the show notes to hear Emil's full story and learn more about how living with hemophilia can impact mental health.
Speaking of the expanded treatment landscape, though, I want to use that as a springboard to talk about satisfaction with suboptimal circumstances or outcomes from a slightly different point of view. I remember when prophylaxis was first introduced, having conversations with guys older than me who would say, "Oh, I don't need that. That's for the younger guys." And then I'd watch them walk around looking like they had gotten hit by a Mack truck. And I think, how could this not be for you? Your joints are compromised. They need protection. How is this? And I would see that and I would think they're entrenched. They just have a mindset that like, this thing isn't for me. And so they won't even consider it. And I think now we have so many options for people that I worry at times people aren't taking the time or don't have access to the education and the information to realize, hey, there's extended half-life products. Hey, there are subcutaneous products that you don't have to administer as often. Hey, there are these rebalancing agents and these other things that you should maybe consider if there's something about your management of hemophilia that's suboptimal. You don't have to accept that. I'm wondering if you could comment not necessarily on those who are reaching crisis level with their entrenched resiliency, but ahead of that, people who are accepting suboptimal outcomes and not opening up their minds to what other options may be available to them. Do you have any comments or insights on that and how we may be able to help people shift their thinking now that there are so many ways to manage hemophilia for most of us?
Well, you have to remember that those over 40 went through a kind of a rough patch when clotting factor was dangerous. And the technique at that time was, I'm not changing anything. And so that mentality has stuck with them. And I will say that once again, in the research we have with the older guys, they utilize less care. They utilize less care. They don't go to the treatment center as often. They report less pain than the younger guys. It's that whole, I'm just going to tough it out mentality. I don't know how you're going to change that. They don't, they will change their treatment methodology when the one that they're using is discontinued. And other than that, they're fine, right? I'm fine. Just keep giving me what I've been using for the last 20 years and I'm fine. I don't know how you're going to change that. So
another word for what I felt Randy was talking about is generational trauma. And that is the impact that trauma plays in our community. And it's really interesting, Patrick, because I think so much of I'm fine has to do with PTSD in general. Avoidance is one of the 4 criteria of it. And so I was, number one, love the work that Kate and her group did of PTSD and post-traumatic stress symptoms. And I also like that this is a unique opportunity to talk to Donna too about what would happen if our HTCs became more informed or more sensitive to trauma-informed care too, because that's another mechanism where a treatment center can really recognize quickly signs and symptoms of mental health disorders related to trauma within the facility.
It's interesting. Not only did I do hemophilia care, but of course, practiced oncology. And, trauma-informed care actually came to oncology way before it ever was even considered in non-oncological, in the treatment of non-oncological patients. And that is, we stopped doing procedures on children, just holding them down and doing with a local anesthetic, and started using propofol. And suddenly, all of the trauma that you were hearing emanating from oncology patients stopped, and the clinics became silent, and the clinics became non-stressful places for children who were coming in for diagnostic and therapeutic care. But that said, I think that the perception of that trauma is also behind the widespread adoption of emicizumab, since that is a much less traumatic way of treating particularly the youngest children than IV infusions ever could be. So as therapeutics evolved in hemophilia, the need to really study this and pursue it has diminished somewhat. And hopefully, due to advancing therapeutics, the damage, the psychic damage and the PTSD from a therapeutic milieu will diminish, I think, as we go on with the future. So I was thinking, okay, number one, how have the root causes, as we get less traumatic, and hopefully PTSD becomes less of an issue, disability associated with hemophilia becomes less of an issue. How do we understand the root causes of anxiety and depression in individuals with hemophilia? And what is that intervention? Should the guard come down, and should we be able to, move past the I'm fine? What do we do? What's the intervention? How should hemophilia treatment centers sort of pursue this and make a difference in a pre-crisis way?
I'm so glad you said that, you asked that question, because I've been involved with that for quite some time. One of the things I have involved myself with is Sanofi is working on that too, which is beyond the past 2 years. We're trying to figure out with the HTC landscape what's reasonable and what could be achievable. Just understanding too, let's not even mention the fact that the crisis that our federally funded HTCs are under right now. And so there is already a limitation of time and resources.
With these treatment programs is especially these state-based programs or the programs funded by, let's say, Medicaid, they're underfunded and understaffed. So the line to get into an inpatient facility is extremely long, and therefore these programs tend to cherry pick sometimes who gets a bed. And that's not me making that up. We actually were told that by a treatment program when we were interviewing them, is that they have such a long line to get into their doors that they're really just picking the people who they feel are the less complicated patients, even if that's not the reality, even if it's not true.
So we're looking for simple ways to address this, and I really think it's a paradigm shift. What I'd like to see, Donna, is maybe we get rid of the PHQ, or the GAD, to test the GAD, just test for generalized anxiety disorder, and put something more simplistic, where we're looking at the person as a whole. Mark Skinner's done a lot of work on the probe assistance, like mental health. So that's one of them. And then I think that we should be maybe more forward thinking. We know that bleeding disorder creates so much anxiety and strife and uncertainty. So maybe we can make an effort to strategically put in coping skills training for children, or something like that. Just automatically assume it's affecting an individual and create programming around it.
So as my job as a clinical social worker, it's to assess for behavioral health needs, right? I utilize evidence-based tools to assess for mental health or substance use issues with my patients, starting when they're kids, actually. So a patient will come in, I actually start around age 10, and I ask some difficult questions, right? But they're important questions to ask.
If you look at the data in our community, about up to 58% of people with bleeding disorders report significant symptoms of anxiety. About 63% of people with bleeding disorders report significant symptoms of depression. And I think harking back to the PTSD conversation earlier, about 12%, some work that Amanda Stahl did out of the Boston Hemophilia Center looking at PTSD in adults, about 12% of people with bleeding disorders experience PTSD. And so I think there is a real opportunity to focus on addressing these issues in the context of the Hemophilia Treatment Center. And I think that the fact that the full range of treatment modalities, specifically the access to inpatient and residential mental health and substance use treatment, requires that we begin to have these conversations earlier and incorporate it into the regular cadence of conversations that you have in your comp visits.
By doing this early on, we can address any struggles a person may be facing before it actually becomes a crisis. And I use this statement all of the time with my patients, so they kind of understand why I'm doing this. It's better to be proactive instead of reactive, right? This is something called early intervention, which is key for behavioral health issues. Early intervention is a process of recognizing the warning signs of a mental health or substance use challenge and acting before it gets worse. For example, the goal of early intervention for, let's say, substance use is helping you identify the substance misuse, or let's say a mild substance use disorder, before it gets worse or it does any harm, okay? So early intervention identifies the underlying issues and triggers and gets people connected to treatment in real time. I truly believe this is the most critical and important thing that we can do for people with bleeding disorders. If we are able to get somebody with a bleeding disorder who, let's say, has a few warning signs of a substance use disorder, connected to a therapist or a group such as like AA or Alcoholics Anonymous, before it reaches the point where they need residential or inpatient treatment, they will be able to learn the skills and interventions needed to deal with whatever is happening in that moment in their life.
And I would say, from a patient perspective, I agree, because my hemophilia treatment center is where I feel most comfortable discussing my health in general. So it's the environment as a patient where I am most likely going to be willing to bring up, like that gentleman did in the story that we shared at the top of the episode, and that's the inspiration for Kate's organization. He brought it up in the context of his hemophilia treatment center. And I'll just say, as a point of personal reflection, I always felt as a child even that when you came into the room at the end of our visits, Dr. DiMichele, that at that point, everyone had already gotten the bleed counts and done the range of motion measurements, and there had already been all the blocking and tackling. And I always felt like at that point of the visit is where things got most kind of high level or holistic, words I wouldn't have used as a 12-year-old. But I think in practice, you did bring that more holistic point of view to your care because of who you are. I don't know that that's necessarily standard. Maybe it is, maybe it isn't. I would guess not, just because there's 140 treatment centers. So people do things different ways.
Knowing that our treatment centers were developed in the 70s, and think about how much we've all changed in treatment opportunities. I really want to point to the idea that social workers are letting us know that what they would really like to be doing is counseling and intervention. And, according to a study in 2021, the ideal versus the actual, it said that 51% of them would see counseling as their ideal role as a social worker. And it says 13% feel like that they get to partake in this. And so I would love to see in integrated behavioral health incorporated into our H2C role.
I think one of the most important things for us to be doing in the community at this moment in time, both with community members and with HTC providers, is to make sure that we are talking about these issues. And again, to really encourage people to have these conversations early. Have conversations about mental health and substance use before they reach crisis level. And I think that is probably the number one takeaway from this conversation and this work.
I'm also going to issue a challenge here at the end of the episode, and that is to my fellow blood brothers and blood sisters and community members. The challenge is don't wait. If we only talk about mental health in moments of crisis, we miss the chance to intervene early when access and opportunities for care are better and outcomes can be changed. By normalizing resilience, we risk silencing pain, but when we start talking sooner, question unchallenged satisfaction, and demand systems that don't turn us away, we move closer to a more honest, responsive, and equitable standard of care. Thank you all for listening to the Global Hemophilia Report. And if you are struggling or were triggered by any part of this conversation, you can call the Suicide and Crisis Lifeline at 988. It's available 24 hours a day, 365 days a year by text or call 988. Thank you to Jackie Bottacari, Debbie De La Riva, Randy Curtis, and Kate Bazinsky for their contributions. If you liked this episode, check out the library of past episodes at globalhemophiliareport.com or search Global Hemophilia Report wherever you get your podcasts. This episode of the Global Hemophilia Report was made possible thanks to our featured advertiser, Sanofi, and special thanks to Dr. Donna DiMichele, our senior scientific advisor, and to Keith Cornelick, our producer. This episode was written by Kay Vermeil and edited by Japneet Dhaliwal. We'll be back next month with another critical conversation. My name is Patrick James Lynch, and until then.
Sanofi is committed to bringing new perspectives and bold innovations to the global hemophilia community. Learn more about how Sanofi is committed to breaking barriers and supporting the community at redefininghemophilia.com.